So it's 9 o'clock. We'll give 5 minutes, but let me introduce Sanjay Govil, sir. He's a very senior uh, lead surgeon, hepatobiliary surgery and liver transplantation, and he has been a wonderful teacher over the years, who I've seen giving many talks, especially on cholangiocarcinoma. So his special area of interest is cholangiocarcinoma, and today's topic, while not applicable to cholangiocarcinoma, is a very interesting and very debatable topic, which is ALPS. And this debate actually is now settling down, and ALPS is becoming one of the tools in the armamentarium of hepatobiliary surgeon. So, welcome, Dr. Sanjay Govil.
Thank you very much. Thank you. Looking forward to participate.
You can start.
Yes. Good morning, sir. Myself, Dr. Rohith. I am from Stanley Medical College. My topic of discussion today is ALPS. It's controversial and it is becoming regularized by these days with advanced liver surgeries. I will go and discuss with ALPS. ALPS is basically associating liver partition and portal vein ligation for a staged hepatectomy. So the evaluation is ALPS is basically it is a modification of the two-stage liver resection combining two established surgical techniques, that is the right portal vein ligation and in situ splitting of the liver. Hans Litt initiated the concept of ALPS in 2007 while he was resecting a case of perihilar cholangiocarcinoma and abandoned it due to a technical difficulty. So when he abandoned this technical difficulty, he transected the liver and left it, and anesmos did hepaticojejunostomy to the left liver. After a few days, he identified a massive hypertrophy of the left lobe, after which this technique has become popularized. Schitt introduced the term right portal vein ligation and in situ splitting of the liver. Basically, it is a combined technique of PVL plus ISS. So the ALPS terminology was proposed by Santibes et al. In 2012 in the first time in Annals of Surgery. The rate of complete tumor resection has been higher after ALPS compared to any other liver augmentation technique. However, high morbidity and mortality has raised the concerns of ALPS. So coming to the indications of ALPS, bilateral colorectal liver metastasis remain the most common indication for ALPS surgery. Other indications are HCC in a cirrhotic liver, and it was first done for hilar cholangiocarcinoma, but perihilar as well as for intrahilar cholangiocarcinoma, the indications are controversial. They are not regularized, they are not popularized, and there is no definite guideline. Basically, ALPS procedure is considered in patients needing major liver resection in whom the FLR is deemed to be insufficient during the pre-operative workup. Coming versus ALPS versus other liver augmentation technique, the most commonly used portal vein embolization or simply a portal vein ligation either in a two-stage hepatectomy. Then when is ALPS proposed is an extreme volume gain is needed, or when the tumor load is present within the FLR, and when both portal vein embolization or portal vein ligation approaches are either not applicable or have failed. So the term used when if these augmentation liver procedures has not been possible, it is called rescue ALPS. When the FLR requirement is minimal, so definitely we are telling when the FLR requirement is minimal, portal vein embolization should be the first choice because it is associated with less morbidity and mortality. So where volume gain is more, where FLR is very less, ALPS is an option. Contraindication for ALPS are extrahepatic liver metastasis, severe portal hypertension, high anesthesia risk, and other medical contraindications same as to any other major hepatectomy. Coming about the FLR is usually assessed, you may know that it's a popularized CT volumetry, very thin section should be used. While discussing regarding the FLR for a liver surgery, both an radiologist as well as operating surgeon should sit together, discuss regarding the FLR, how much it is, and then come to a proposal of whether to proceed for ALPS or not. So we already know that less than 20% lower limit of FLR is required for normal livers, but 30 to 35% of FLR is required for a chemotherapy related liver injury, whereas in 40% of liver is required for patients with chronic liver disease.
Just one sec. Am I allowed to interrupt, or should we do you normally just wait till the end and then make comments?
Allowed to interrupt, sir.
Okay, so then can I just make a few comments from what you've already said? Uh, the first thing that you have to remember is that there is, you can actually do an ALPS for any patient with, who needs a liver resection, irrespective of the uh, underlying condition. And but you're right that it is primarily colorectal liver metastasis, and there is a caution for cholangiocarcinoma or any cause or any patient who has a biliary obstruction, because the single largest most significant complication after an ALPS is a bile leak. And if you've got a biliary obstruction, you either have to have both sides, even segment 4, separately what's it called, decompressed, because otherwise you're going to have a bile leak from the cut surface. And that is the main reason why for cholangiocarcinoma, the mortality was extremely high in the early cases. But there have been more recent articles which have said that as long as the bile ducts from the right lobe as well as segment 4 are decompressed, that you can go ahead and do it. Intrahepatic cholangiocarcinoma can also be an indication for ALPS. There's nothing to say that you can't do it for intrahepatic cholangiocarcinoma. I do agree that with your comment that it depends on the degree of hypertrophy that you need, and I probably will discuss that further. And the other thing I would like to say is that this lower limit of FLR of 20% is really, that is what is repeatedly quoted, and it's true in young patients and children with absolutely healthy livers, but it leaves no margin for error. And I think if you did an ALPS in which you had a 20% residual, FLR, if you got the slightest bit of an SIRS or a small minor bile leak or any kind of sepsis, you'd be in real trouble. So I think, although this figure is repeatedly quoted, these are the standard figures we quote. I think in practice, most of us would be very nervous about leaving a 20% FLR, except perhaps in a child. I don't know whether the other Dr. Desai or anybody has any other thoughts
regarding, especially in ALPS, sir.
Yeah.
Most of the time this is colorectal liver metastasis, and
Yeah.
already sometimes these patients will have some sort of chemotherapy received other 4 or 5 cycles.
Yeah.
So the target should be go into the 30 to 35% range rather than the 20% range.
Yeah.
So that's what I wanted to stress.
Yeah.
I basically agree with Sanjay sir. I wasn't aware of these recent publications. So sorry for the comment I mentioned. It is not applicable in cholangiocarcinoma.
No, that's okay.
Okay, sir. Can I continue?
Yeah, please.
Regarding the technical challenges, especially in ALPS. So what else is difficult compared to a routine major hepatectomy is that, so portal vein anatomy should be very clear before the first surgery itself, because especially any anomalies within the portal vein, whenever an anterior sectional right portal branch, that is the right anterior portal vein, if at all is joining the left portal vein, it should not be missed during the primary surgery while ligation. Because deportalization with this technique, when you leave a right anterior posterior vein, will be incomplete, resulting in the reduced hypertrophy of the FLR. So delineation of portal vein anatomy is very, very important, especially intravenous and intraoperative ultrasound helps regarding any of these errors during the surgery. Coming to the biliary anatomy, so Strasberg, Blumgard and Mazda has proposed, we know we have different classifications of biliary anatomy. So coming to basically the common anatomy is the right anterior and posterior common right hepatic duct, that is the type A. It is favorable for performing ALPS. It will be easy. As well as trifurcation, the type B anatomy will also be sometimes favorable, or it will be easy during performing an ALPS. But the complexity arises when there is an anatomy like a C, a D, and type E classifications within the Blumgard classification, where the right posterior sector will directly join the left hepatic duct, or sometimes the right anterior sector will join the left hepatic duct, or complex biliary anatomy like a type E. So these should be delineated very in detail during the before the primary surgery itself. So in order to avoid any other complications such as bile leak or inadequate ligation after stage 2 hepatectomy. So type E occurs greater risk of damage to the left hepatic duct during the stage 2 operation, that is after the initial primary resection. And coming to the middle hepatic vein, it should not be transected at the stage 1 of ALPS unless it is infiltrated by the tumor to maintain outflow of the FLR. So this I will discuss.
So just one second. I'm not sure that these biliary things that you've mentioned are such a. I mean, if you've got a right posterior branch which is going right into the umbilical fissure or something, then you're, obviously doing an ALPS is likely to cause some kind of. You may have a problem, but even so, I don't think the biliary anatomy makes that much of a difference in an ALPS. Yeah, you're transecting just to the right of the umbilical fissure. It's most of the anomalies that biliary anomalies you're going to face are closer to the hilum than the umbilical fissure. So the only I don't think you need to worry too much about biliary anatomy in an ALPS. What isn't it? What do you think, Dr. Rohith? Why would you, if you're doing an ALPS in the umbilical fissure, why would the fact that you've got, separately joining anterior and posterior ducts make any difference to your transection? In a right transectectomy, does it matter?
No, sir. No, sir. But your portal vein is to be more stressed, sir, definitely, compared to
biliary. Portal vein is extremely important. You need to know the anatomy of the portal vein, but I don't think biliary anatomy makes very much difference here, except in relation to the tumor. So, obviously. Okay.
Okay, sir.
Yeah. Go ahead.
So this is the picture which actually depicts the actual procedure what happens in ALPS. When it is less than 30% of the liver, the first stage of operation, usually we ligate the right portal vein.
One second, can somebody mute your a lot of background noise.
हाँ दोस्तों उनको दे दीजिएगा.
Can those who are not speaking just mute them? Okay, go ahead, Dr. Rohith. I don't know who's making all this racket.
Okay, yeah, muted them.
Yeah, thank you.
Okay, thank you. This is the picture actually what has happened in ALPS. So basically, when there is a residual tumor within the FLR, in the first stage of the surgery, this FLR tumors within the FLR has to be resected, as well as the right portal has to be ligated, and there is a transition plane near the level of falciform ligament, or most classically ALPS is usually done for an extended right hepatectomy. So after 1 week, we assess that how much is hypertrophied, or whether an adequate hypertrophy is identified or not, or whether any further new tumors, if at all, have been identified in an FLR. So if these new tumors, if at all present in an FLR, so ALPS have not to be, like stage 2 should not be proceeded. Similarly, after the stage 2, the resection of the deportalization have to be done. So this is what the surgical picture depicts. Initially, there will be equal anatomy, or like large of the tumor will present within the right lobe. After the transition, this volume of the previously deportalized liver should come down, as well as there should be the hypertrophy of the remaining FLR. So what we generally do is that after ligating the right portal vein, the right hepatic duct, also the right hepatic artery, they should be looped some with some named vessels, like we have to use some color things so that to attach there. So during the stage 2, identification of these structures will be easy, and ligation will be proper. Coming to the steps, one right trisegmentectomy. First of all,
again, can I interrupt there? Actually, taping the right hepatic duct will be very difficult and potentially cause problems. So usually what one does is just tapes the right hepatic artery, so that you can, you identify that in the second stage, and we don't usually do anything for the bile ducts at that point, because getting around the bile duct you could potentially injure it, so, and cause a bile leak post-op. So just I don't think you should mess around with the bile duct. Just tape the artery and ligate the portal vein. Leave the bile duct for next time.
Okay, sir. Okay. So macroscopic assessment of the liver should be first done. If at all required, and if you are not confident whether the liver is not proper, or if you identify any sign of cirrhosis within an FLR or a ST2 hepatitis or a chemotherapy-induced liver injury, a biopsy of an FLR can be done. The right liver first should be dissected from the retroperitoneum as well as from all the ligaments, attached ligaments, the triangle ligaments and everything. Lymphadenectomy of the hepatic pedicle can be done because of oncological aspects as well as of the better delineation of the hilum. And the right portal vein can be sieved and can be divided and oversewn with a 50 or a 60 proline, or as well as a vascular endogenous stapler can also be used for ligation of the right portal vein. To continue about the segment 4, what they have proposed is that the portal as well as the biliary structures of the segment 4 to be divided and closed. So I am exactly not sure what this has been described as been surgical technique. I would like to know with my seniors why it has been written in Blumkarts. And total or near total parenchymal dissection during an anterior approach. So this have been done by parenchymal dissection, by anterior approach, by liver hanging maneuver. The resection plane covered with a plastic bag or a hemostatic patch. So after this completion, we have to see whether there is a bile leak or not from the cut surface. So bile leak test to be done. So it is usually what they have given is that it is called a white test. You give an emulsion in the cystic duct, you infuse that and see whether this emulsion has been coming from the cut surface of the left lobe of the liver. So tagged vessel loops, as are already clarified this regarding right hepatic artery, and tumor resections in the FLR, if at all is there, I already told, they have to be done. So after the stage 1, so generally the waiting time is usually 1 to 2 weeks. The minimal FLR is 30 to 40%.
Shall we just go through the details of stage 1 once before you proceed? So you're right. If you need to, you biopsy the FLR. There were a few things that the initial mortality and morbidity associated with ALPS was extremely high. And then there was a registry which was created, an ALPS registry, which had a large number of patients. And analysis of this looked to see what were the causes for the mortality and how they could reduce it. And as you mentioned earlier, perhaps one of the most important things is to make sure that you don't divide the middle hepatic vein. Normally, very often the middle hepatic vein joins the left hepatic vein. So when you do the transection, you very often will, you will divide the middle hepatic vein, and this caused huge amounts of necrosis, quite a significant amount of necrosis, particularly in segment 4, and therefore there was a lot of inflammation and a higher incidence of sepsis and bile leaks and so on. So that is probably the single most important factor, that you don't divide the middle hepatic vein. The second thing that you alluded to was that it is now being increasingly recognized that as long as you do a 50% transection of the parenchyma, that provides the same degree of hypertrophy as doing a complete transection by anterior approach. So unless if you're having any kind of difficulty with the transection, there's bleeding, or you're it's perfectly all right for you to stop the transection at the end of completing 50% of the parenchymal transection. Number 3, with regard to this lymphadenectomy, I mean, basically what was found was that the less you do in stage 1, the more likely you are to be able to go on to stage 2 and achieve a successful outcome. And therefore, although you're right that the entire lymphadenectomy and all that was considered to be an important part of stage 1, it is not necessary for you to do this in stage 1. You can even leave this for stage 2, because excessive dissection in the hilum and even inflow occlusion should be minimized, because for whatever reason, and no one's quite, I mean, not quite clear why, but in the registry data, people who had extensive lymphadenectomy or had or where Pringle was used during transection were found to have poorer outcomes after ALPS. So it's quite acceptable for you to leave this aspect of ALPS for the second stage, in these situations. So these are the main things. And then you asked about transection of the portal and biliary structures to segment 4. Dr. Rohit?
Yes, sir. Yes, sir.
You had a query about that. What exactly was the query?
So, biliary structures of the segment 4 have to be ligated with that. So,
well, they don't have, the biliary structures do not have to be ligated. It can be done in the second stage. Ideally, you should ligate the portal structures, because at least in my understanding, one of the most important reasons why ALPS works, apart from whatever cytokines are released during transection of parenchyma, is also that you're ensuring that all the between the parenchymal transection and ligating the portal pedicles, you're ensuring an S4 venous embolization. I mean, like we talk about right portal vein plus S4 when we do portal vein ligation, portal vein embolization. No,
yes.
Do you understand? Am I making myself clear?
Yes, sir. Yes, sir. Yes.
Yeah. So I think that although you don't need to do this, if you're doing that 50, if you're having difficulty, you'll get a better outcome if you ligate the portal pedicle going into into segment 4. So very often it means that you end up ligating the bile duct as well, but not necessarily. So you should aim to divide that pedicle, segment 4 pedicle.
Okay.
Okay. And the bile leak test, what is used is, you were talking about emulsion and all, but the simplest thing
we use
is propofol.
Yes, sir. Propofol.
So that's what, in most of us, I think nowadays are using propofol to check for a bile leak, and that's what we would use in an ALPS as well.
Okay.
Yeah.
So usually after the stage 1, the waiting period is 1 to 2 weeks. The expected hypertrophy should occur within the margin of less than 14 days. So because we can't wait for waiting a long time of stage 2, because there is already a plastic bag which can
that's the other thing. This plastic bag is no longer used. It's no longer used. It was described in the early patients in whom you do ALPS, but precisely for this reason, that many of these patients require to wait longer than a week. The plastic bag is no longer used, and it's not terribly efficient. The idea of the plastic bag is that if there was a bile leak, it would remain within the plastic bag. It doesn't happen like that. So the plastic bag really doesn't help. So nobody uses a plastic bag anymore. Yeah, go ahead.
Okay. So the in situ split adds to the deportalization of the ipsilateral, that is the right lobe, by cutting any of the portal communication that may reperfuse from the contralateral lobe and reducing the portal venous occlusion less efficient. Because if the in situ split is not proper, there is a chance that the cut end of the liver surface can have some communications or collaterals from the left lobe, so making the portal venous occlusion less efficient. The surgical trauma of the parenchymal transition with the release of the cytokines may enhance the process of the liver regeneration. So what happens is this: the in situ split adds to the deportalization because of stopping the collaterals or communication from the left lobe to the right lobe, making it more efficient. And the post-surgical trauma cytokines causing liver regeneration, as well as the hyperperfusion.
Not from left lobe to right lobe. Yeah, it's basically ensuring a portal vein embolization of segment 4. I don't think, maybe a little bit from left lobe to right lobe as well, but you're essentially ensuring that not only the right portal vein is blocked, but also segment 4 is not getting any portal flow at all.
Yes, sir.
It's a complete portal vein occlusion of segment 4.
Yes.
Yeah.
So hyperperfusion of the hepatic artery is most important because whenever the portal vein is ligated, the hepatic artery flows will increase. So it is required to maintain the function of the FLR because during this 1 to 2 week period, the liver should not go into an accelerated liver failure. So in order to the presence of hepatic artery blood supply and the venous outflow for the resected, especially the deportalized segment, is very important to prevent liver failure during the waiting period, and or until unless the FLR has been hypertrophied.
Yeah.
So interval phase 7 to 14 days. The cutoff value to proceed to the stage 2 or the standardized FLR 30% or 40%. The standardized FLR for 30% is the body weight ratio of 0.5% of the graft or 0.8% of the FLR. So sometimes these need to be combined with a quantitative liver function such as HIDA scan, because sometimes you can see or you can get an adequate hypertrophy of the FLR, of an FLR as per CT volumetry, but the quantitative function of the FLR has been questioned because of previous chemotherapy associated liver injury or associated liver condition. So this is not commonly done, but it may be required because of the extent of liver injury in the before proceeding to stage 1 operation.
So the main thing is that in any hypertrophy that you get in the liver, the hypertrophy is and especially in ALPS, the hypertrophy is always first in terms of volume, and function follows volume.
Yes.
So because the first thing that will happen here is that you're going to get not congestion is not the right word because there's an outflow, but suddenly you've got a huge diversion of portal flow into the left lateral segment or whichever part of the liver you're preserving. And so the concern is that some of the hypertrophy is related just to that. So I think it's always a good idea to get a functional, especially if you're doing it within 7-8 days, which was the original recommendation for ALPS. The earlier you're doing the second stage, I think the more important it is for you to get some kind of volume, some kind of functional status. A HIDA is actually a very good way of making this out. We don't use, at least we don't have the facility of being able to say what percentage of the function is in this lobe and what percentage in that lobe. But you can see a clear, when you do a HIDA and when the liver is ready to be transected to go on to phase 2, you will see that almost all the tracer uptake in a HIDA is in the, I would say at least two-thirds to 3/4 of it is in the remnant. Then it's quite safe for you to proceed. This is an eyeballing thing, I'm afraid. I don't have the numbers, but there are, it is available in the literature for you to find out what the numbers are, if you can assess it quantitatively. But we generally eyeball it, and sort of if there's almost all of it is in the FLR, we just go ahead to the second stage.
Most of centers do that, but if at all, this have to be also be kept in mind and have to be considered.
Yeah.
So coming to the stage 2 of the surgery, excision of the deportalized previous liver has to be done. The local anatomy is actually modified due to the hypertrophy of the FLR. So because of this hypertrophy of FLR, the local anatomy is somewhat difficult to identify during the stage 2. The right hepatic vein as well as the middle hepatic vein is divided, as you can see in this picture. Both MHV and RH were divided, and the liver has been surviving with the left hepatic vein. And intraoperative cholangiogram can be done in order to check the biliary continuity. So it depends upon the surgeon expertise and as well as the local availability during in the center. So I can be done to check the biliary anatomy. So this is a actual picture of a patient with an adenocarcinoma or with colorectal liver metastasis. So where there is an extensive metastasis in entire right lobe, large metastasis in segment 8, 5 and all, and as well as in the 2 and 3. So what they have done in this study picture is that, so they have resected the segment 2 and 3 as well as they deportalized the right lobe, and the only liver surviving is the 1 and 4, because these are the only liver segments which have not got any sort of metastasis. So this is after the ALPS procedure, where there is an extensive hypertrophy of the 1 and 4 with around 30% compared to the total liver volume. So this was the picture of metastasis in the segment 2 and 3, which they have resected in the stage 1, as well as the depotalized part of the right lobe, and this is the surviving segment 1 and 4. So this is after stage 2, after the stage 1, and after near approximately 9 days. So this was the picture, intraoperative picture showing large hypertrophy of the segment 4, which is being survived by the left hepatic vein. So this was a nice picture showing that. So the variance in surgical variance is the classic ALPS. We already know that we are resected to the right of segment 4. Sorry, to the left of the segment 4 and 4B. So the central ALPS has also been proposed by division which are at the level of Cantel's line after ligating the right portal vein without ligating the structures to the segment 4. So similar techniques for the left extended hepatectomy, which are not that popularized, as well as the central ALPS, which I have told now with an example, where the 2 and 3 is resected in stage 1 along with the depotalization of the right lobe, and the only surviving segment is segment 1 and the segment 4. So the diagram which I have showed is central ALPS. So there are different modifications in ALPS which has been described in literature. The ALPS, partial ALPS, ALPPS, and the RALPS and the hybrid ALPS. So out of this, the most popular is partial ALPS. As already saw told that 50% have transition surface will achieve a similar amount of the FLR, and it helps in reducing the morbidity of the procedure. So which is most commonly done out of these all modifications, most popular is this partial ALPS. So complications and how to avoid them in ALPS. So already Saar told that about the postoperative bile leak, which causes the high morbidity after ALPS. The most common bile leak occurs from the segment 4 bile ducts. This causes a biliary fistula postoperatively, as well as intraoperative collections, biliomas, and the sepsis. So sepsis is the most threatened complication during this operation, and it is the most common cause for morbidity as well as mortality. And the next most important is the postoperative ascites, and the most severe complication is liver failure, which is the leading cause of death post ALPS. So liver failure and sepsis, these are the two harms for the surgeon. So if these two are both addressed properly, ALPS will really be successful. So how to avoid this? As previously discussed, minimal hilar dissection during the stage 1. That was what we are stressing. Use of intraoperative cholangiogram and the white test or the propofol test or the fat emulsion test in stage 1. Safeguard the middle hepatic vein in stage 1 to maintain the outflow of the both depotalized as well as of the FLR. Accurate 3D volumetric calculation, most important, and the use of colored plastic loops during stage 1, which I have discussed that only for hepatic artery, if it is done, it is enough, not for the hepatic duct. So coming to the ALPS registry, in the first report of the International ALPS registry, including 202 patients with the perioperative 90-day mortality was 9%. The risk factors for increased morbidity as well as mortality is RBC transfusion during the stage 1 procedure, and duration of stage 1 procedure greater than 300 minutes, and age is more than 60 years were identified as significant risk factors. ALPS registry found that the major lethal outcomes actually occurred after the stage 2 procedures. So patient selection after the stage 1 and the timing of stage 2 will be the most crucial aspect. So decision making is important for an adequate outcome. So coming to the results after morbidity and mortality after ALPS, various
one of the other things that they found, I don't know whether they're going to discuss this later, but the important thing is that you don't proceed to stage 2 in a patient who is septic or in a patient who has ideally in a patient who has a bilirubin more than 2. That it's better for you to wait and allow further hypertrophy to carry on and get a controlled biliary fistula rather than proceeding to stage 2. So it's one of the principal causes of mortality in the registry was that everybody thought that since the first ALPS was done, the second stage was done after 7-8 days, that one has to immediately do the second stage after 7-8 days. But that's not correct. It's much more important that the patient stabilizes, comes out of sepsis, the bilirubin comes down, and the patient is stable enough to proceed to a second stage. It doesn't matter whether you have to wait 2 weeks or 3 weeks or 4 weeks. That is a secondary of secondary importance. So don't be if you've done a stage 1 and you've run into some trouble, manage the problem in stage 1. Don't rush into a stage 2, even if you've achieved the volume that you wanted.
Okay. The only problem while if you use a plastic bag.
Yeah, you should not use a plastic bag. That is obsolete. It's not recommended. In fact, nobody uses a plastic bag.
Okay.
Do not use a plastic bag, because do not do anything that forces you to go back in. So even the loops that were put on the hepatic artery, what I use is I use a long proline sort of slip knot. I tie it like a slip knot and leave that in there rather than using any kind of other plastic thing which to leave behind. Don't do anything which forces you to go back in at a time when the patient may not be fit enough to do that. So what you're talking about, plastic bag, was the original description, the very early descriptions of ALPS. For years, nobody has recommended putting a plastic bag anymore. Okay. So do not do anything that forces you to go back in a hurry.
Okay. So these are the results with ALPS by various studies in 2012 to 2015. So with advanced in techniques as well as the better understanding of this procedure, the morbidity from 68% is slowly coming around to 40%, whereas the mortality rates are maintained in around from 6 to 12% based on different center experience. Because the number of patients were high in 2014 by Shadin et al., where 202 patients are actually registered in ALP registry. The mortality it showed was only 9%. So other studies has also proposed with 0% mortality and 36% mortality in 2015 by Hernod and et al. So with advanced techniques, morbidity definitely coming down and mortality almost remains stable.
Yeah. So just if you look at this list, the Nadalin paper, 15 cases, 28.7% mortality. This is the original experience with hyalocholangiocarcinoma. And that's why it was recommended that you should not do ALPS in hyalocholangiocarcinoma. These were all hyalocholangio patients. Shade is the registry from which all the recommendations that you mentioned have been taken. Hernandez Alejandro is the paper in which they started preserving the middle hepatic vein, and they found that there was no segment 4 necrosis. And the mortality was 0 in this small group of patients. So that was where the big, one of the big sort of, if you want, technical recommendations was from the Hernandez Alejandro paper.
Okay.
Yeah.
So this is the long-term outcomes after ALPS. The most important is like this surgery is actually being done for colorectal liver metastasis. So we have to improve the disease-free survival as well as the overall survival for these patients. Where the Shadin et al., where 202 cases were done for colorectal liver metastasis. So disease-free survival at 2 years was 41%, and the overall survival was nearly around 62%. So this was the good result from Shadin et al. After the long-term outcomes after ALPS surgery. So other centers have also proposed 1-year survival rates around 56% in 2015 and 94% in 2014, as well as the Hernandez et al. In 2015 has 1-year survival of 84%. So the overall survival has also remained stable nearly to 80 to 100% at the end of the 1 year in various studies after ALPS. So providing good oncological outcome compared to where other colorectal liver metastasis surgeries.
Would you call this a good outcome? Would you call this a good outcome? You will get almost 100% 1-year survival with
2 years is
chemotherapy. Yeah.
So
you'll get 60% outcome with chemotherapy at 2 years.
But the long term with the ALPS is really waiting, sir. So once if you get the long term outcome and
long term outcomes are available. Anyway, we'll discuss that later. Yes, but sir. All I'm saying is that I think it's you can't really say If you have a patient with a colorectal metastasis and you have a 1 year survival, or you don't consider that a great success, no? Do you consider that a great success if
No,
you've
sir.
got a
No,
1 year survival with a resectable colorectal liver metastasis?
if after 5 years, if it is something in history, I will say it is okay.
What will you accept as a 5 year survival in colorectal
Up to
metastasis?
5 years survival, up to 50% to 60% is good.
Yeah, that's excellent. I mean, it will probably be a little less than that, but yeah, somewhere around, yeah, maybe 35, 40% to 50%, that kind of thing should be okay. Right.
So this was the meta-analysis of ALPS proposed in University of France, where that ALPS does not replace conventional two-stage hepatectomy or portal and embolization, but rather it provides an additional method when these techniques are not expected to result in insufficient hypertrophy. So this was what that was proposed in this from Switzerland, including multiple centers from France. So what the results were like this. So the increase in FLR compared with ALPS and portal embolization, the increase in is 76% in ALPS, whereas that is 37% with portal embolization. And the completion of the stage 2 was almost 100% with ALPS, as well as it was only 77% with portal embolization, where the p-value was significant. The morbidity and mortality rates compared with ALPS and portal embolization, definitely it is higher with morbidity and mortality is higher with ALPS compared to portal embolization, but they proposed it was an insignificant p-value. Whereas in multiple non-comparative studies, the complication rates were 39% with portal embolization group, and it was 47% with the portal ligation group alone, and 70% with ALPS. After the stage 2, the mortality was 5% in portal embolization, 7% with portal ligation, and 12% in ALPS group. As already discussed, the mortality is around 12% in this ALPS group. So this meta-analysis has given an overall picture that the completion stage 2 and as well as increase in FLR definitely with ALPS is higher, but the morbidity and mortality is higher compared to portal embolization with an insignificant p-value. So what other literature says is that regarding ALPS, the challenging concept of unresectability, a systemic review by Kimberley and et al. In 2014. So what the discussion was that ALPS is only indicated when the two-stage hepatectomy is necessary and the FLR is deemed inadequate, less than 30%, but its use in poor functional outcomes in status like advanced 70 years of age is cautioned. So discretion should be used when considering these patients with pathology other than colorectal liver metastasis, especially with the hilar tumors requiring biliary reconstruction. The biliary ligation during first stage and the routine lymphodectomy of the HDL should be avoided. So this was the proposal from this center that routine lymphodectomy is to be avoided, and as already Sir told that we can leave it to the stage 2 operation. So this is another review article in 2017 by Department of General Surgery in Germany, that is in situ split liver resection bar ALPS, the historical development and current practice. So what this proposed regarding ALPS is that it is a great new technique, rather a new addition to the armament of the highly experienced HBV surgeon. Every surgeon using this technique should have the entire spectrum of techniques, interventions available in order to select the optimal surgical approach for each individualized patient. So this is a tailored approach. So it should be picked up for each individual patient with colorectal liver metastasis. That does not mean that all colorectal liver metastasis have to undergo ALPS surgery. So another paper from China, this is in 2013 about ALPS. So what they concluded is that ALPS has emerged a new strategy to increase the resectability of hepatic malignancies. High morbidity and mortality of ALPS procedure, the surgical candidate should be selected carefully. Moreover, there are very limited available evidence for its technical feasibility, safety, and oncological outcome, which are needed for further evaluation in large-scale studies. So about the conclusion, ALPS effectively increases the resectability rates of otherwise inoperable liver tumors by achieving a rapid and effective hypertrophy of the FLR. The high perioperative morbidity of the procedure makes the selection of patient very crucial. Limited knowledge of technical aspects of the procedures makes its learning curve unusually long. The data on long-term oncological outcomes are promising and comparable to the conventional hepatectomy, but further prospects need to be followed. So what is expected in future? It is likely that this technique will continue to be done in specialized centers only with adequate expertise. Multiple randomized control studies with longer follow-up required. The newer method of liver surgery and whereas the better postoperative management in liver ICUs have brought down the morbidity and mortality of ALP surgery, but still needs to break down these numbers to make it more popularized. Thank you.
Thank you, Dr. Rohith. I'd just like to give my perspective, which is perhaps slightly different from. I think, as far as I'm aware, the first person to do an ALPS in this country. And I published a paper in HPB surgery on this the same year as the presentation by that Hans Schlitt published his. And initially I used to do some ALPS, but my feeling now is that this is a very high morbidity procedure, and that particularly with, if you do portal vein embolization of the right lobe with segment 4 embolization, and especially if you are able to add hepatic vein embolization to that, that you are able to achieve, pretty similar results, degrees of hypertrophy to an ALPS in these patients without subjecting them to two operations very quickly, one after the other. So I think ALPS is definitely something that we do still continue to use very occasionally. But it is more, like you said, a rescue procedure, in the sense a rescue or a salvage procedure, where if we haven't been able to achieve the degree of hypertrophy that we wanted, or when we open and then we find that, oh, actually the liver looks, doesn't look as good, and we want to get a bigger volume, we might do a partial transection and ligate and come back for a second stage. So I'm much more cautious about doing ALPS. Secondly, the gap between the first and second stage is unimportant. You need to, the 1 week, 10 days, all those kind of things, you don't need to bother about. You do it when you've achieved your purpose and when it's safe to do it. There is a lot of concern about this procedure, because you may have seen there have been a couple of publications, one indeed from Germany itself, and one from China, where they have looked at all the publications on ALPS, and they found that 30% of all publications were published in one single journal, where the senior author of that journal was a proponent of ALPS. And an even greater majority of all the positive outcome papers were published in that journal. So there is a concern that there has been a real publication bias in favor of ALPS. Secondly, if you look at all the publications, 90% of them are on, as you have mentioned, technical aspects and short-term outcomes. Patients, who go home, or maybe a 1-year follow-up. But there are many other publications which have reported that, the disease-free survival at the end of 1 year after an ALPS for colorectal liver mets is only, around 15%. So you're not giving, although you are doing a technically complete surgery, you're right in that you're able to go on to the second stage much more frequently in patients who have had an ALPS. It also means you haven't had a chance to study the biology of the tumor, and very often you're doing this for tumors which are involving the entire liver. And the recurrence of tumor after ALPS is very rapid in some of these patients. So I think you need to be a little bit cautious. It is a useful technique, and it's been shown that, it's 11 times the rate of growth of the liver is 11 times faster than in patients who have had a portal vein embolization. But that need not necessarily be a bad thing, in the sense that if you've got a tumor that is going to grow and recur or metastasize, in a few weeks' time, the chances that you're going to get a good outcome for that patient are quite poor. And there is even one publication which has directly compared patients who have received ALPS and those who have received only modern chemotherapy. And there is no difference in survival between these two groups. So I think ALPS needs to be taken cautiously. It's a useful technique when it is necessary and in certain clinical situations. But even recently, when I was in New York for the, I was part of that first ALPS study group in Hamburg. And I met Professor Oldhafer and some of these people who were leading the charge for ALPS at that stage in New York recently at the IHPBA World Congress. And he also said, he asked me, how are you doing with ALPS? I said, I haven't done one for the past 3-4 years. And he said, yeah, I've also stopped doing it. So just be cautious. There's a huge publication bias for this procedure. It's a useful procedure, but it needs to be done in very, very selected patients. And my own recommendation would be do it only in patients as a salvage or a rescue procedure and not otherwise. I mean, I'd be happy to listen to any comments or any questions, and if there's anything else that you want me to discuss.
There was just one comment from literature that the hypertrophy, though it is there, and it has shown growth markers and hepatocellular hypertrophy markers, the cells themselves are very immature.
Absolutely.
And therefore, functionally, they are not as capable as in after portal vein embolization.
Yeah, that's what I said, that always volume precedes function. Function follows volume. So when you're going in, that's why when you're going in at the end of 1 week, like was the original recommendation, the likelihood is that you're not going to have you may have the volume, but you likely do, there's a good chance you may not have the function. And that's why if you're going in early, although it's not a standard recommendation, whenever I have done an ALPS, I have always done a HIDA scan before doing the second stage. But if you wait for 2-3 weeks or longer, like you have to when you're doing a portal vein embolization, by then the function has caught up with the volume. And therefore, you don't need to do a functional status. It's not necessary for you to do a functional status. You're absolutely right. That is definitely a big concern. And I think, you should not be rushing in to do the second stage of ALPS. If you had to do an ALPS, so I would just say be cautious about who you select for ALPS. Minimize the procedures in the first stage. Delay the second stage if the patient is in sepsis or has jaundice. Don't use things like plastic bags and various things which are going to force you to have to reoperate early. I mean, and if you're don't be in a hurry to do the second stage. Make sure that conditions are optimal before you do the second stage. That's basically, I think, the important things about ALPS. I mean, I did 8 early on, and I haven't done any. We had lost one patient. We had one bile leak, and I haven't done one for the last 3-4 years at least.
It's brings you down to the base level very quickly if you select poorly, and if you do it frequently, you're going to land in trouble. So that's where ALPS is at now.
Yeah.
But ALPS in colorectal liver metastasis is sort of seems to be picking up.
I don't think so, sir.
Okay.
I don't think so. I think for the reasons that I mentioned, that there are, I mean, you have only a 15% disease-free survival at the end of 1 year with an ALPS. Secondly, you don't have, though you may complete the operation, you don't have a handle. I mean, the whole principle of two-stage hepatectomy is not just that to clear out the remnant of tumor, but also to give you time to see what the biology of the tumor is.
Do you use chemotherapy before an ALPS procedure?
In most of the published series, they have not used. I don't think. No, they have used. They have used. They have used in the published series. The patients that I have done have not been for colorectal. I think only one was for colorectal mets.
Oh, sure. So you're mainly doing it in cholangiocarcinoma.
So I did it. I did a few for actually GB carcinoma, which had infiltrated the the anterior, the right portal pedicle inside the liver.
Sure.
Then I did for colorectal. I did for hyalocholangiocarcinoma, and I did for intrahepatic cholangiocarcinoma.
Sure.
Yeah.
Yeah. So it's about 10 now. So if you have any doubts, anybody, please you can put it in the message box, and then we'll wind up within 5 minutes.
Okay, I think everybody seems to be very clear. So that was a good presentation, Dr. Rohith. But I would urge you to also look at those papers. There's a recent Chinese one which has highlighted the bias in publications on ALPS.
Okay, sir.
Just have a look at that.
Okay.
I think it's within the last 1 year. The German paper is some years ago, but there's a big publication bias. Lot of even the fact that it was called ALPS is because it was the Swiss group that popularized it. It was devised first in Germany, but it was the Swiss surgeons who popularized it, and they used this anyway.
Rohith, are you able to see any questions in the chat box?
No, sir. No, sir. No, sir.
No. So there are no more doubts. We close the session for today. Thank you very much, Dr. Govil, for enlightening us, because it's been really an experience of learning with you. And I always enjoy your talks wherever I hear them.
Thank you so much. It was a pleasure. It was mine entirely.
Thank you, sir.
Thank you.
Thank you. So I'll end for everybody. So
Thank you.